Hello there. Welcome to today's session. We're going to get started. So before I introduce our session and speakers, just a couple of housekeeping items. If you're having any technical difficulty, please email as noted in the chat to Capacity Building, and our colleagues will do their best to help you out. Also, today's session is being recorded and will be posted on the PHO website in a few days along with the slides. So we're very fortunate to welcome two high caliber speakers presenting today PHO's webinar, Applying Resident and Family-Centered Infection Prevention and Control Principles in the Hospice Setting. Their expertise and passion for infection control is unparalleled, and at the same time, they're both very practical in helping people from a variety of care settings to apply those IPAC principles. The information and examples they'll provide will help you to build upon what you already know about IPAC and hospice, and the opportunity to share your experiences and learning with each other. As we always say, you're the real experts. So during today's session, it should be very helpful to assist you to move that bar on your hospice IPAC program. So introducing our speakers, Anne Augustine's professional background is in medical laboratory technology. She has been board certified in infection control and epidemiology and held that designation since 1991. Anne has experience working as an infection prevention and control professional in a variety of healthcare settings, including long-term care, tertiary, rural acute, and public health. At Public Health Ontario, Anne is an acting manager of health systems guidance of the COVID-19 IMS. She's also active within IPAC Canada as a member of the Standards and Guidelines Committee, Long-Term Care Interest Group, and Reprocessing Interest Group. Dr. Jaya Nataraja is an infectious disease physician and medical microbiologist. At Public Health Ontario, she's a co-lead of the health systems guidance stream of the COVID-19 IMS and an IPAC physician within health protection. She's also the medical director of IPAC and microbiology laboratory at Oak Valley Health with locations in Markham and Uxbridge. I'm Lori Dawn Boyer, and I'll be moderating this session as well as some of the interactive elements. With me is our colleague, Melissa Miller. Melissa and I are both IPAC specialists within Public Health Ontario. On to today's objectives. So the idea behind holding this webinar grew out of the situation created by the COVID-19 pandemic, which has highlighted the integral role of infection prevention and control in the provision of care across all healthcare settings, including residential hospice settings. These facilities, the facilities that you work in, provide respectful, compassionate care. At times, applying IPAC principles and best practices in an effective way may feel very challenging in these environments, as we can appreciate. This session will discuss how IPAC principles can be applied to maintain the focus of care on the resident and their families and friends while embracing the unique care environment within hospice settings. This presentation was first delivered as part of a workshop at the Hospice Palliative Care Ontario Conference in April 26th of this year, where it was very well received by the participants, and we're encouraged to offer the information more broadly. So we're pleased that our presenters have agreed to present within a webinar format today in order to allow a broader audience to participate. Our speakers will review and make evident the essential IPAC measures applicable for your care environment, discuss how your policies, education, and training that you provide can help with the successful implementation of these IPAC measures, and then have a really practical discussion about how the places we work in and the humans we work with may help or hinder your IPAC efforts. We have some ideas for you to consider, but really hope that you'll share your previous successes and ideas as well. I'll pass it over to Anne now to get started with the presentation.
Thanks so much, Lori Dawn. So let's consider, what is the goal of infection prevention and control? The goal is to prevent the transmission of organisms or infections while maintaining a focus on compassionate end-of-life care. So why this goal? Well, because we want to provide a safe environment. We want the environment to be safe for clients and residents to receive care. We want it to be safe for families and visitors to come and visit. And we want it to be a safe place for staff to work. So this is a snip from the Infection Prevention and Control Resource Manual for residential hospice settings developed in 2010 by the Hospice Association of Ontario, Public Health Ontario's regional infection control networks, and the Ontario Public Health and Provincial End of Care networks. While it is an older document, so much of it is still very relevant, and we have included it in this presentation because we feel the need for compassion in the application of IPAC is key. And this particular item is speaking about the use of gloves and how traumatic it can be for family to have to don gloves when caring for a loved one. So as the statement says, prevention is essential. So if we prevent the transmission of organisms and/or infections in the first place, gloves will not be required. And sometimes gloves are needed when providing care. For example, if a so that there will be no further transmission, but we don't want to wear gloves unless there is an indication for the use of gloves. Wearing them without a sound rationale, it will put residents and staff at risk. And lastly, we want people to consider, why are the gloves being worn? Is it because the person has MRSA? I mean, gloves are part of contact precautions. However, if a person is sitting with their husband who they've lived with for the last, say, 2 years in their own home, and the person has been colonized with MRSA that entire time, why are we asking them to wear gloves when they're sitting there reminiscing? There's no need for the gloves. So while it is very important that we consistently apply IPAC best practices, we need to consider the compassion too. So let's think about routine practices to start with. So routine practices refer to infection control practices that are used by all care providers with all residents at all times. And the goal here is to prevent the transmission of organisms in all healthcare settings. So routine practices are to be incorporated into the culture of the healthcare setting, into everything you do in providing care to the resident. And it will protect the resident and it will help protect the healthcare provider. So every time you interact with a patient, a resident, a client, think about routine practices. So the iceberg that we have here is a nice visual to help us think about routine practices. The tip of the iceberg, that is what we know about the person. That's the infection we know about because they're presenting with signs and symptoms. And it's the information we know, say we know they're colonized with MRSA. The bottom of the iceberg, however, that's what we don't know about. And there is always a potential that a person may be ill with or carrying an infection, for example, hepatitis B, MRSA, a carbapenemase producing Enterobacteriaceae that we're not aware of. So by using routine practice, our goal is to prevent the transmission of these things that we are unaware of. And the routine practices starts with your point of care risk assessment, moves on to hand hygiene, takes into consider where the resident is going to be placed. So what's the roommate like? What's the roommate's health status? We think about environmental cleaning, shared items, the room itself, the greater communal spaces. We also think about organizational policies. For example, healthy workplace, meaning do not come to work when you're sick, okay? It's particularly when you have a respiratory illness or a gastrointestinal illness, or if you have conjunctivitis, those can spread so quickly in the workplace environment. So there should be policies and procedures in place regarding that, and also policies and procedures regarding resident and staff vaccination. And then we think about hand hygiene at the bedside. So hand hygiene is probably the best known IPAC strategy, and yet sometimes it is the hardest one to have consistently implemented in any setting where care is being provided. In their document, Hand Hygiene Practices in Healthcare Settings, the Public Health Agency of Canada states, adherence to hand hygiene recommendations is the single most important practice for the prevention and transmission of microorganisms in healthcare and directly contributes to patient safety. I would argue that if hand hygiene directly contributes to patient safety, it will also contribute to the the care provider and volunteer and family safety. And so for these reasons, we want to emphasize hand hygiene at the bedside. So Public Health Ontario has developed the 4 moments for hand hygiene, and I'm sure many of you are already very familiar with this program. However, for those who are not, the 4 moments of hand hygiene lays out when hand hygiene should be performed. So before contact with the resident and or their environment, and the rationale here is to protect your resident from organisms you may have acquired while moving through the organization. Then before any aseptic procedure, for example, assessing an IV line, and this is to protect the patient from their own organisms. And then after potential contact with a known contact with blood or body fluids, and for instance, after you've been helping a resident with the toilet or done dressing, when you remove your gloves, you're going to clean your hands. And then finally, after you leave the residence area or leave the resident or their environment, you want to clean your hands. And the rationale there is so that you don't take the resident's organisms with you into the rest of the organization. So it's a big order, you might be thinking. So how can an organization support their staff, volunteers, and families in doing their hand hygiene at the correct time in the correct manner? Well, one is to ensure that there is access to alcohol-based hand rub or hand washing facilities everywhere. Put it everywhere where it's needed. It could be in the entrance, in the hallway, in activity rooms, dining rooms, outside the residence room, in the residence room. Give the residents a squirt of the alcohol on their hands as they enter into a dining room or an activity room. Or when their meal tray is delivered, then they can clean their hands. And if the resident or client is unable to clean their own hands, give them a bigger squirt and clean your hands together. Make it super easy for everyone to clean their hands. Education and training also is key. For staff and volunteers, this should be done at orientation and on a regular basis or when required. For example, when a resident is placed on additional precautions. And that's the point where families and friends could also be reminded with respect to their hand hygiene. Or if there's an outbreak, everyone in the organization should be provided with an update on hand hygiene. And then there's auditing, and how this is achieved will really depend on your organization. It could take the form of auditing for compliance using the Just Clean Your Hands audit, or it could be asking residents if staff clean their hands before providing care, or it could be an audit of ABR dispensers. Say, are they in the right places? Are they being filled consistently? Is the product being used? However your organization plans to do auditing, it should be done in a comparison with best practices, and feedback should be provided to those who are being audited. It will help identify the gaps and to help you provide a plan for correcting. And then there is the point of care risk assessment. This is really quite, along with hand hygiene, this is really quite a cornerstone of IPAC. The point of care risk assessment is a practice that, the majority of healthcare providers do each time they interact with a resident, but they may not put a name to it. So when you're thinking about preventing the transmission of microorganisms between the residents, you're doing your risk assessment. Think about, what is the resident's infection status? Do they have an infection? Are they colonized? Do they have MRSA? Do they have a wound with copious drainage? And what are the characteristics of the resident? Are they able to follow instructions? Are they really forgetful? What type of care activities are you going to perform? Is there a risk for exposure to blood or body fluids? And what resources do you have available to you to help control? Do you have the right PPE? Do you have point of care hand hygiene? Do you have sharps containers? And of course, what's your health status? And then in assessing the risk of exposure, what kind of contamination could I be coming into contact with? Will my skin or clothing be potentially contaminated? Will I be exposed to blood, body fluids, secretions, excretions, non-intact skin, mucous membranes, exposure to contaminated equipment or surfaces? All of these are the kinds of questions that healthcare workers need to ask themselves. And by thinking about these factors and potential exposures, healthcare healthcare worker can make an informed choice with respect to the personal protective equipment they need to provide the care. Now, going back to the the Infection Prevention and Control Resource Manual for the residential hospice settings, we really like the approach that they've taken in this document to doing a risk assessment. And this might be really helpful to you in your teaching of others of how to perform a risk assessment. You can see that they've divided it into 3 different assessments: task-related assessments. So what equipment do I need? What is the care provider's skill? What's the risk of contact with blood and body fluids? And then the second one is a resident-related exposure. Again, thinking about your residents and their ability to comply with the care that's going to be provided, but also about continence, drainage from a wound, and then also engineering control. So what do I have in place? And so we've put some examples of some types of care that you might provide in the hospice setting. So think about those types of care and the 3 different assessments and how that would help you. And sometimes we need to use additional precautions. Additional precautions refer to IPAC interventions used in addition to routine practices. These interventions could include the use of PPE, placing the client in a single room. Of course, private rooms are always the preferred accommodation. Dedicating patient care equipment, having to clean equipment otherwise if it's shared. And it could mean increasing the number of times you have to clean the resident's room. Say if the resident is colonized with vancomycin-resistant enterococci or VRE, or if the resident has C. difficile, it could mean changing the type of cleaner or disinfectant that one has so that it's better at killing spores. The interventions that are used are targeted at the mode of transmission of the organism because we want to interrupt the transmission of the suspected or identified infectious agent so that the infection won't be killed. So let's go through a couple of examples. So these transmission-based precautions, contact precautions, thinking about methicillin-resistant Staphylococcus aureus. This organisms move from one person to another on the hands of healthcare providers or by contaminated resident care equipment. So the intervention, single room, all shared resident equipment is cleaned between residents, and that is part of routine practices as well. However, I want to highlight it here because MRSA can be transmitted by contaminated resident care equipment. Healthcare workers do their hand hygiene and they wear gloves and maybe a gown depending upon the care that is going to be provided. And then they remove their PPE when the care is completed and dispose of it into the correct bin and clean their hands. Then thinking about droplet precautions. It's not used on its own frequently, so let's discuss droplet contact precautions in the context of influenza A, as influenza A season comes around pretty much every year. So influenza A is transmitted by droplets produced by coughing and sneezing, and they travel about 2 meters, and they can land on you, on your portals of entry of your face, your eyes, your nose, and your mouth, and infect you. Or they can land on surfaces in the environment, and you can touch these and then touch yourself, because we're always touching our faces and our eyes, and then you infect yourself. So to prevent this from happening, the interventions are a single room for the patient, cleaning the patient room as usual. But now, if you had an outbreak, you would increase the cleaning of the high-touch surfaces in the unit and where the affected resident was residing. And again, as per routine practices, you clean all the shared equipment between patients. But here, the healthcare workers need to don their PPE. Mask, eye protection, glove, and gown. The mask and eye protection protect the portals of entry on your face, and the gown protects their clothing, and the gloves and protect the hands. Of course, hand hygiene has to be done before you don your PPE and when you remove your PPE. And then lastly, there are airborne precautions. Here, the organism is in a droplet nuclei and has the potential to stay suspended in the air for long periods of time. I chose disseminated shingles as an example, as your patients are very immunocompromised, and this is a time when the herpes zoster can present itself in the form of disseminated shingles. When shingles are disseminated, then the transmission of the herpes zoster virus is by contact of the vesicles, but also by the airborne route. A patient with this infection will need to be cared for on airborne precautions, and this means a single room, negative pressure, preferably with an anteroom. And the room is to be alarmed for shifts in pressure. That is, if it loses its positive pressure. Only immune staff or those who have had chickenpox are to provide care. In my experience, it is unlikely that a hospice would have an airborne isolation room, so you may have to transfer your patient to facilities that have those capabilities. Now, this is a snip from PIDAC's document, Routine Practices and Additional Precautions in All Healthcare Settings, Appendix N. I've found this over my career to be a very useful chart, and it sets out the types of additional precautions that are needed, the room accommodation, how long the precautions should be in place, and any special comments. So here we have respiratory syncytial virus. What is required? Droplet contact precautions. Do they need a single room? Yes. How long do I keep them in precautions? Until they have started to improve. No, there are no special comments for this particular organism. So this has been a super helpful document, and you may find it helpful in your setting as well. And then we talk about IPAC at the bedside in single rooms. And this, in his paper from 2006, the essay Evidence-Based Healthcare Architecture, Roger Ehrlich, a professor of architecture at Texas A&M University, states that infection rates are lower when patients are in a single rather than multi-bed rooms, and the air quality is very good. So this, I guess, is my my push for single rooms. If you've got an opportunity to get all single rooms, this is the push for it. So why are the infection rates lower when you have all single rooms? Well, because you're able to have separation of your clients. If one patient is infected or colonized, say they have norovirus, then the ill patient will not have the opportunity to contaminate the living space or the washroom of another patient, because they each have their own room and they each have their own toilet. So you have a lower risk of contamination. And because they each have their own room, you have less clutter, so things are easier to clean. I have what I thought was a great positive deviant. And so this was when I was working in a small rural hospital, and the diagnostic imaging area was all forever saying to us, you never tell us when people are on additional precautions. You never tell us. And yet the staff were like, we always enter it into the computer system when the person's on precautions. They just don't read it. And so we had this conflict. And so the ward clerk, she was getting, I think she was just getting tired of having to constantly say, it was entered, it was entered. So she went shopping through the little thing of hospital gadgets, and she found these dials which had the colors of red, yellow, green, and blue, which were the colors of our signs that one person was on additional precautions. And when someone was put on additional precautions, she put it onto their paper chart and dialed up the color. So when you walked onto the unit, you would see all the charts. And those who were on precautions, the little dial was on there. And so when the chart went upstairs to diagnostic imaging with the patient, the chart was sitting with them or handed to the diagnostic imaging, and the dial was right there. And you could see what kind of precautions the person was on. Didn't even have to open the chart. So it was a really great way to do it. to communicate something that, even though we've been trying to communicate it through the official means, this was a much more expedient way, it seemed. And then because it was only implemented on that one unit, because that's where the one person with the positive deviance was, all the other units were like, hey, can we have that? We really like that. And so that was a really positive change. Has anybody had something like that?
So we have had a few responses come in from our participants, Anne,
Mhm.
with some ideas about how to address some of the barriers that they've seen. So I'll just share a couple of those ideas. Some of them are the same among different participants, so I'll do my best to provide a synopsis. So to me, it really seems to all come down to communication, where wherever there are barriers, often communication can get you past that barrier. So a couple of people have commented that providing frequent updates to staff and volunteers is helpful, and being available to address any questions or concerns as soon as possible when they come up can sometimes help avoid habits that you don't want to see form to become ingrained. Um, Others have provided that giving like one-to-one feedback during activities like PPE audits or hand hygiene audits, right at the time that things are happening, have been really helpful to kind of help move the needle on some of those practices. Others have commented that they find the biggest barrier is that if people don't understand the rationale for what we're asking them to do, often
Mm.
they don't see the reason to change their practice. So saying that often once it's explained to people, they're sometimes more accepting of the best practices and willing to participate. So there were a couple of other examples here as well, but I'll let you move on, Anne, and I'll look to do a synopsis of those.
Yeah, excellent. Well, I think it's time for us to move on to Jaya's portion of the presentation. So uh, take it away, Jaya.
Thank you, Anne. So I'm going to go through a few slides that really talk about some of the practical implementations of things that you can do on the bedside, but also some of the rationale, as was commented in the chat box, on why some of these are IPAC best practices. And one of the things that we really focus on is the patient or resident's environment and what's around them, because we consider a patient could be potentially infectious or a resident could be potentially infectious, but so can the environment around them and contribute to transmission of infection. And when you look particularly in a hospice setting, the residents have a lot of personal materials that is there. It's very important to them. It's very important to the family as well. And some of the things that we consider in those environments is how easy are they to clean? What are the choice of materials you have within that patient environment? These materials and finishes should be compatible with hospital grade cleaners and disinfectants. And when it comes to the stuff that's owned by the actual hospice, they need to be replaced very quickly when stained and torn, and any cracked items. And really, we want to have the resident keep some of their precious items within their environment as well. So we might as well make the rest of it as cleanable as possible so they don't transmit infections. Surfaces around the resident should be easy to maintain and repair, easy to clean, smooth, and non-porous. And one of the most important things that we really find as a barrier to IPAC is clutter. And very important to declutter as much of the patient's or resident's environment, as well as the rest of the setting in the hospice as possible. So how do we clean effectively at the bedside? And often at the bedside, it's not just being cleaned by the professional cleaning staff. Often us as the frontline providers also have to provide some of the cleaning at the bedside. And so we do need to know a little bit about the practical cleaning techniques that actually do stop infection transmission. So we know that there are established protocols for environmental surface professional staff in all healthcare organizations. Those are all best practices. And one of the examples is about high-touch surfaces. And all high-touch surfaces should be cleaned at least once daily in a healthcare setting. But cleaning at the bedside often also falls to any one of the healthcare providers who are at the bedside. So things like shared patient equipment or shared resident equipment, how do you handle laundry, waste management, and soiled surfaces often comes down to people who are also not actually fully trained as environmental service workers. What's really important about cleaning at the bedside is to clean your hands. So you could touch a whole bunch of things. You don't know what you've touched, but as long as you wash your hands when you come out of that environment, you know that you're not transmitting to yourself or to anything around you, which is why that hand hygiene step is so important. Appropriate use of PPE is important when you're cleaning. So not just for infection transmission, but because you're also handling these potentially caustic cleaning agents. So handling and application of cleaning agents and disinfections are very important. And it's very important to prevent blood and body fluid exposures when you're cleaning, as well as sharp safety as well. So there are some really key principles for cleaning and disinfecting, and we have a series of exercises that we've sent into the field through the Ministry of Health called Action IPAC, which is really practical, quick little exercises you can do for us to really think of IPAC in a very practical way, where we're not memorizing what we need to do, but it just comes naturally to us as well. So for effective disinfection, which is where you actually kill the organism, you have to make sure that any soiled surfaces was first cleaned of dirt, dust, organic materials like blood and secretions, and then you disinfect. And we've provided some very important practical information about what disinfectants are. They must have an official drug identification number. They must be used in the correct dilution. If you don't want to use a highly concentrated disinfectant, it doesn't make it any better. You want to make sure you dilute it, but not over dilute it. A really important aspect for those of us who are not professional cleaners but are cleaning a resident environment really quickly, or cleaning between staff, between procedures, is that whatever surface you clean has to remain wet with the disinfectant for the recommended duration of time, which is called the contact time, and then be allowed to air dry. So if you're cleaning that area with a half-dried cleaning wipe that you've pulled out and the containers remained open, you're actually not providing any disinfecting ability at all. So prior to the use of any cleaning agents, make sure you review the label for what precautions you need to take, like if you need to wear gloves or not when using it, and ensure that the product is in good condition. Check the expiry date, but most importantly, that top wipe, if you're not closing the lid, is always dry. And it's one of my biggest pet peeves in our organization is to see those lie open. They're not providing you appropriate disinfection. So just a few practical things to consider at the bedside. So decluttering is very important. Clutter has very strongly been shown to increase the risk of healthcare-acquired infections. I don't think any one of us has ever seen a non-cluttered healthcare setting. But the main reason clutter increases the risk is because it actually impacts your ability to clean the environment. The more clutter means the more items become more contaminated, and then those can transmit infection when they're touched. And there are some organisms like VRE and C. diff that get transmitted very well through surface contamination, while others aren't as important for surface transmission. So some of the things you can do, and we call these the 4 R's of decluttering, is reduce the things you take into your resident rooms. Bring only what is needed. Don't leave a whole bunch of dressing trays or medical equipment in there if you're using it. Try to just leave what's important to your resident, but any of the medical items that you take in or clinical items, cleaning items, really reduce that. Remove any used care items, excess linens, papers, equipment, things that are not needed in there. Remove them immediately so you keep it nice and open. Refresh your healthcare environment, whether it's in your care room, your team room, or hallways, by basically just rearranging furniture so you're exposing all of these forgotten surfaces that have never been cleaned before. So I'll spend a few more minutes on indoor air quality. And this has really come to surface during the COVID-19 pandemic. We've learned quite a bit about how air quality can really affect infection transmission. Certainly, there's a lot of other important aspects of air quality for other things other than infection transmission. And essentially, you can improve your indoor air quality by removing stale indoor air and supplying it with fresh outdoor air. And this is what's called ventilation. You're basically diluting out any infectious particles in the air. And we've all learned about the 3 C's. Closed spaces, crowded and confined, means there's less airflow, less air circulation, and therefore a higher chance of infection transmission if someone who's sitting in that space with you is potentially infectious. And these are some really quick tips for what you can do today when you get back to your office or back to your care station to really get a quick handle or a quick pulse check on how good the air quality is in your workspace. Is your HVAC system inspected and up to code? Do you notice, look at your air vents. Are they actually blowing and returning air? Are there 6 inches of clearance around them? If you hold a little tissue, will it suck it in? Is it stuffy in your office space? Are there lingering odors? When somebody heats up their food, does that odor last for half an hour, 1 hour? Are there drafts? One of the things you can do very quickly, if you have exhaust fans in your workspace, like in bathrooms or little kitchenettes, you can run those exhaust fans, and that actually does help circulate air inside your facility. Look at all of the rooms in your facility. Is there furniture, drapes? Is it crowded? Open up any windows that you can. That's a really quick method to get in some fresh air into your room. So I'll give a couple of slides on the next portion of our presentation, which is talking about a healthy workplace. IPAC is a measure of health and safety. It's everyone's business. And a healthy workplace is where workers and managers can collaborate to improve the health and safety of all workers. And really, a big part of IPAC is the psychological health and safety of your workplace. A lot of your comments were around communication, not understanding the rationale, and feeling safe and being able to have a healthy workplace impacts IPAC quite a bit. So I'm going to hand this over to our next colleague, who's one of our PHO's psychological health and safety leads, to talk about how the physical environment, the organizational environment, and the tools and technologies that we have provided. We have tons of tools and technologies when it comes to IPAC, but what's missing is the human factor. And what are the human factors that really increase or decrease the risk of spreading infections to other staff or residents? All right, Loredan, it's yours.
Okay, thanks, Jaya. So I'm just going to go over, we just have a few slides left, and these slides that follow, I'm just going to speak a little bit about human factors and how it affects IPAC practice and our communication with each other. And then I'm just going to present some ideas for you to think about. And if you have ideas to address some of these barriers or potential issues we may have faced, please contribute to the Q&A, and we'll pull things together and hopefully have time for a couple of examples and maybe a few questions. So please continue to put questions in the chat box as we go. So when we think about how we actually work in that environment, thinking about what Jay has just said about a healthy workplace is where we can collaborate. Really, to enable open collaboration, the key is to creating a work environment where everyone feels safe to speak openly about issues in the workplace, with a focus on finding solutions and making improvements. So we've heard some very practical things that can be done to support IPAC good practice in the hospice setting, but we know that sometimes, despite our best intentions and having policies in place, sometimes these things don't actually happen in practice. So for example, we know that we need extra cleaning to be carried out as indicated, or we know we need hand hygiene to be done at the place and time when it's needed. But what can we do to provide people with what they need to be able to do what we're asking them to do? And this is where human factors, tools, technologies intersect with IPAC. So healthcare, as we know, this is a complex system with a lot of interacting components, and we can benefit from human factors engineering. So thinking about what that is, so the components are individual factors or people, the tasks we're doing, and then the technologies are tools, the organization we're in, and the environment. So human factors are usually considered and applied in workspace design, but the applied science here is called ergonomics, which is concerning with designing and arranging the things that us people use so that the people and the things interact most efficiently and safely. And so When things are easy to do, for example, when you have your hand sanitizer where you need it when you need it, it's a lot easier to sanitize your hands. So that's the kind of principles we're thinking in mind. In my mind, the confounder here can be the humans and our ways of communicating or perhaps not communicating. So thinking about hospice, we're looking for a home-like environment. A calm environment is one without clutter in many people's minds. And as we've heard from you, sometimes there can be a lot of clutter present as a barrier to effective environmental cleaning. So patients and families may wish to have their familiar objects in their space or may have more personal belongings than you and your hospice can actually store neatly and facilitate environmental cleaning. So this means that we need to, balance priorities and look to do what we can to kind of optimize the environment for infection prevention and control. As well, Anne talked about, put hand sanitizers everywhere. Well, some people don't want to see hand sanitizers mounted everywhere because we're trying to achieve that home-like environment, but it's very necessary to enable staff to observe the 4 moments for hand hygiene. We know that having that sanitizer readily available where it's needed lets staff perform hand hygiene when we're asking them to do so. So there can be some discord between creating that home-like environment while having what may be seen as medical equipment in the resident space. So in addition, just again, kind of wrapping up the pieces of human factors, we need to consider how usable things like a hand sanitizer dispenser actually is. Is it easy to dispense? Does it become clogged and potentially spray into someone's eye? That's not good. Is the reservoir large enough that it doesn't have to be replenished too frequently, yet not so large that the sanitizer expires because it hasn't been used? And things like how satisfactory are the contents? And there was a question earlier about how do you deal with skin breakdown and skin condition with ongoing use? So all these are considerations within human factors as well. So I'm just going to scoot really quickly through the elements that come together. Whenever we have humans interacting together, it's a mix of the working conditions as well as our management practices. So it's very important to have create an environment where IPAC is valued and demonstrated as being valued by the leaders, as well as the staff demonstrating that value to the clients and residents. This positive deviance culture, looking for answers that are really in front of our eyes, that the experts at providing care, our staff and ourselves within the hospice setting, we know what needs to be done and sometimes the best way to do things. But if we don't have that culture of open conversation, it can be very difficult to bring that forward. Again, that strong feedback culture, that openness to speak and not receive retribution for it. Paid sick days is very important, and hopefully we're moving that way in Ontario and in Canada. It's hard for people to stay home when they're ill if it provides a financial burden for them. Vaccination policies as well as IPAC education and training are also important. So we have a few questions just for you to think about. I'm just going to move through these fairly quickly as we're coming towards our time to wrap up. So thinking about, and these are questions that you can consider bringing back to your team to have a discussion, to start to open up the possibilities of speaking freely and speaking openly. So one question that we're certainly interested in your experience, but also you may be interested in hearing about the experience of your colleagues and staff is, have you experienced a stressful time at work? And are you finding it difficult some days to come into work? I think this is something that many of us may have been experiencing and maybe still are experiencing. Do you feel comfortable to share your struggles with your supervisor, manager, or coworker? And so this is just for your consideration as something that we would want people to answer yes, that they are comfortable, and do what we can to kind of create an atmosphere where people can answer that question to the positive and also move forward. So another thing to think about and maybe ask your staff and have some discussion with as a team, and this can kind of open the discussion about psychological health and safety without being so explicit about it. So asking people, you know, when you volunteer for a special project or you make yourself available for extra shifts, do you feel appreciated? Do you feel acknowledged? Because we're all tired, but I mean, often we will go that extra mile if we feel like it's recognized, valued, and that we're actually helping people. Most of us are in healthcare because we want to help the people. What if your coworker pointed out that you forgot to wash your hands? Would you appreciate that feedback? Maybe you could just pop in the Q&A, yes or no. And I think many of us, if we were prepared to have that question sent to us, especially in front of clients or their families, we might not react so positively. But there's an example from Positive Deviance of a team that agreed that they would use like a secret password. I think it was Nurse Florence or something like that, just to indicate to a colleague that they had missed washing their hands. So they didn't have to come out and say, hey, you didn't clean your hands, go back to the sink. But they could say, oh, I was just chatting with Nurse Florence, or whatever their secret word was. And because the colleagues knew that that was the secret word for don't forget to wash your hands, they could kind of do that in a way that wasn't so confrontational and that they were prepared to receive. If you made a sharps handling error, do you feel like you could speak freely with your supervisor or manager? And that's our last question. Last question for your consideration. Think about taking these questions back to your team to start to have a discussion, have that openness. And I know many of you have provided some really great feedback. And Melissa's doing a great job of putting some of those responses together, feeding so that we can all see them. So we're just coming up on very close to our time now. Please do stay on. Stay on the webinar. We are going to do a final poll in about 30 seconds, just asking you for your evaluation feedback. The recording for the slides will be posted in a few days. The slides will be there as well. You see the email address here, ipac@oehpp.ca. If you have any additional questions or you want to get in touch with our speakers, please email that address and perhaps put Hospice IPAC presentation in the subject line. Okay, well, thank you everybody for all of your feedback, your attention. We're really happy that you attended and happy to be able to provide the information again to your group. Thanks again for joining us, and we'll see you next time.